second to leukemia. And in adults, brain cancers don't feature in the top 10 list of cancers. As such, they don't get much attention or airtime in medical school or in general practice. But it's not a trivial problem. Roughly about 1/3 of patients with cancers develop brain metastasis. Meningiomas are the most common brain tumors, and I'm sure many of you have had patients in primary care where meningioma is on their diagnosis list. And glioblastoma is also one of the most common and aggressive primary brain malignancies. And today is November 1st, and I think it's very timely that we are hosting this webinar today. I read the excerpt from Minister Ong Ye Kung's Instagram post this morning, which recognizes family medicine as a medical specialty. So we have shifted the center of gravity of our healthcare system away from hospitals to our community. And I quote him, family doctors are essential to the shift. They are our trusted advisors who help us to manage our health and stay healthy. They also play an important role in coordinating multidisciplinary care in the community. So once again, I want to welcome all of you to our GP Symposium. And I want to introduce our first speaker for today, who's Dr. Jann. He's an associate consultant in the pediatric hematology oncology at KTPH National University's Children's Medical Institute at NUH. He completed his medical training at Duke NUS, followed by pediatric residency specialist accreditation in NUH. He's now advancing his subspecialty training in pediatric hematology oncology with a clinical focus that includes brain and solid tumors, as well as childhood leukemia and cellular therapy. So he'll be giving us his overview of pediatric brain tumors. And while he's giving his talk, I would invite you all to post any questions in the Q&A box, which we will address after his talk. Over to you, Jann.
Okay, thank you, Dr. Bala. Let me just share my slides. Okay. So I hope everyone can see my slides. So thank you for the introduction. So I'll be talking about pediatric brain tumors, mainly for the general practitioner. So just an overview of what we see and the importance of family medicine or family specialties in dealing with pediatric brain tumors. And frequently, they are the first touch points for patients. So like Dr. Bala alluded to, the significance of the pediatric brain tumor is that it is the second most common occurring cancer in children, up to 20, estimated to be about 20% as a group. And this is second only after childhood leukemias, which is about 25 to 35%. And it is the most common solid tumor in childhood. And it is also the leading cause of cancer death in childhood. Although the overall survival as a group has increased to about 75%, the delay in diagnosis is not uncommon. This is because the symptoms that the child may experience may be quite subtle to be at the start and only be picked up later on. And delays have been shown to be associated with worse neurocognitive outcomes, but not necessarily a mortality benefit if picked up earlier. So the types of pediatric brain tumors we deal with are mostly low-grade gliomas. So you can see here the percentage or proportion of pediatric brain tumors. Majority would be the pilocytic astrocytomas or other gliomas. Thereafter, the diffuse gliomas, and then also medulloblastoma, of course. And we also have the rarer pediatric brain tumors, such as craniopharyngioma, germ cell tumor, ependymoma, and meningiomas. And of course, the typical location for younger children is that of the posterior fossa tumors, such as in medulloblastoma or low-grade gliomas even. And as you become older, the tendency is that the tumors are more typically supratentorial, and this will define the symptomatology that the patient presents with. So as a group, typically in terms of the presenting complaints, I like to divide it into the different age groups that you see the patient. For example, the infant who is less than 1 year old may only present with macrocephaly. So as a GP or family practitioner in the polyclinic or in your own practice, you may see that the child's head circumference is rising rapidly, causing, let's say, 2 centiles in a short span of time. They may also have irritability, vomiting, which are quite non-specific symptoms. and also failure to thrive. So some children have this have this syndrome called diencephalic syndrome, where they look hyper alert, but they're very growth stunted, and they actually have failure to thrive. And of course, you may also have developmental delay. In toddlers, which are the age group between 1 to 4 years old, the main thing that you might see is gait disturbance. This is because the location of the tumor is typically in the posterior fossa and typically compressing onto the cerebellum. And because of this, they may have ataxia, which you can see as the child tilting to the left or to the right, and even developing more falls than is normal for the age group. And of course, you can also see the typical classic raised ICP symptoms of vomiting, headache, and even lethargy and irritability. And when the child is a bit older, between 5 to 9 years old, you may see the tumors that are affecting the hypothalamic region or the pineal region or the optic tract. And you may have things like visual changes, visual changes, seizures, delayed growth, delayed puberty, and even diabetes insipidus. And finally, you have adolescents. They can typically present with seizures and also behavioral or school change, besides the usual raised ICP symptoms. So in terms of the things to look out for is mainly headaches, which are most common. And typically, a lot of children do present with things like migraine or tension headaches, which is quite a common complaint. But the things that we associate with red flag symptoms are headaches that are especially worse in the morning with nausea and vomiting because they're lying supine overnight and the raised ICP builds over time. You can also have the gait disturbances, like I mentioned, in the infants or toddlers. And like I mentioned earlier as well, infants, they can be very less specific because they're a bit hard to examine and the child cannot really tell you anything. But you might find they have irritability, poor feeding, failure to thrive, and very important is the macrocephaly. And we can also have visual changes and seizures, typically in the older children and adults. So the benefits of early detection mainly stems from the fact that if you have prolonged symptom to diagnosis intervals, you usually have worse neurological outcomes. And I think it's quite self-explanatory. The tumor typically grows and compresses on crucial structures. And over time, these deficits become less reversible or irreversible. And if you have a smaller tumor, if you catch it early on, you can possibly have a less invasive surgery or reduce surgical risk. You can also initiate rehabilitative and supportive intervention earlier. And although people have looked at the outcomes, we do have improved neurological and neurocognitive outcomes, but there isn't a significant overall survival improvement if you detect early. And because of this, I'd like to just bring attention to other countries that have had successful brain tumor awareness campaigns. So one of the campaigns was that of Head Smart, which is a Be Brain Tumor Aware UK campaign that was started in June 2011. And it was basically a QI strategy to reduce the diagnostic interval between pediatric brain tumor diagnosis. So they reduced the total diagnostic interval from 14 weeks to 6 weeks, and the time from first medical contact to CNS imaging from to 1.4 weeks. And they included a few champions per institution, as well as a lot of materials that were distributed to the schools, nurseries, general practitioners, hospital, and they also have a website for guidance. I think so that's the new name. And again, they do have age groups and try to determine what symptoms are considered red flags. And if there are any red flags of these symptoms, they recommend that the child be seen by a doctor for urgent referral to a tertiary center that can do brain imaging. So in Singapore, we do have our own points of contact. So if you do find that you are worried about a patient who has a brain tumor or have red flags, like I mentioned, you can actually refer them to Children's Emergency. We'll be happy to see them at NUH, or if the patient stays closer to KKH, of course, you can also refer them there. And we also have urgent appointments that you can schedule through the VUC, Viva University Children's Cancer Center, or outpatient clinic. So I just like to quickly touch on the principles of therapy and late effects before I go into the cases that the case vignettes, just to illustrate how the children can present. So the main principles of therapy for a pediatric brain tumor is actually multidisciplinary. So frequently, the pediatric oncologist usually coordinates care, but we get input from ophthalmologists, ENT, neurosurgeons, of course, because they are important in the treatment of the tumor itself, radiotherapists, and endocrine, depending on what the child has. Surgery is a key component of managing pediatric brain tumors in terms of diagnosing and the maximal safe resection if applicable for that tumor type. And after which this child will undergo risk stratification, depending on the tumor type, depending on the biological characteristics of the tumor, and may receive adjuvant chemotherapy or radiotherapy. And the importance of RT is that we must balance the toxicity. It has been shown that if you give RT very early on to children less than 3 years old, or some studies now even say less than 6 years old, that the neurocognitive outcomes can be very bad. For example, you can lose quite a number of IQ points, like 30 or more, if you radiate very early on. And nowadays, there is advancement in the molecular biology of brain tumors, and we can identify molecular targets that we can exploit, such as BRAF inhibitors. Maybe you have heard about vemurafenib in your patients with melanoma. So we can also use it for these patients. And the importance of supportive and rehab throughout, because although we can treat the tumor, we still need to allow the child maximum input in terms of their development. So just a brief about surgery. So typically, we do surgery when the diagnosis is in question. And of course, if we do a biopsy, it may reveal potential molecular targets, like I alluded to earlier. And it can also be therapeutic. For example, in our low-grade gliomas, we always aim for maximal safe resection because this has been shown to improve outcomes and can be curative for some of our patients. Of course, this is more difficult in sensitive areas along the optic tract, or for example, in the posterior fossa near the cerebellum, it may be more difficult to resect the tumor in entirety. Similarly, high-grade gliomas, we also do maximal safe resection and RT or chemo. Things like embryonal tumors, medulloblastoma, ATRT. We do try to also do maximal safe resection and chemo RT. And during the emergent setting, of course, we have our surgeons who go in who may insert EVD or a VP shunt just to reduce the ICP. This is Dr. Bala's domain, but basically radiation can be curative or adjuvant after surgery to reduce sterilized residual disease. And it may also be palliative. So we have patients who have diffuse midline gliomas or DIPGs who cannot be cured with current standard of care, but may benefit from RT in terms of prolonging their life as well as reducing symptoms. But the main problem with radiation, although less nowadays, is that we can see defects in neurocognition, endocrine problems, and even secondary malignancy. There is an option of proton beam in places like Biopolis, SGH, and private sector. And proton beam can spare the surrounding normal tissue and may potentially reduce late effects. Chemotherapy, which is mainly the uh, bread and butter of neuro-oncologists, is can be curative or palliative as well, and it is adjuvant with RT and surgery. And this is mainly to target microscopic disease or to reduce the tumor volume prior to surgery. And not all tumor types may be sensitive to chemotherapy, such as ependymomas. And the main thing is that the chemotherapy or the limit of systemic chemotherapy is that the blood-brain barrier limits the drug availability to the tumor, and hence surgery and RT are needed. And you cannot just give chemo alone, such as in, let's say, a leukemia. And the cons of chemotherapy, of course, is the bone marrow suppression, organ toxicity. We use a lot of cisplatin, and platin agents can harm the hearing cells in the ear. And because of that, they frequently need hearing aids after a while. And of course, not to forget the supportive therapy that is important in acute management. Typically, these children are admitted to ICU, and neurosurgeons are the first touch because of the raised ICP symptoms, because we do see them in these acute kind of settings. And we typically give IV DEXA to reduce any swelling and relieve the raised ICP with shunts. Other domains are neuro rehab. We get the PT and OT to come in to regularly assess our patients and also give them exercises so they can develop well. We also bring in our colleagues from child development, because eventually these patients, after receiving all sorts of therapy, will have attention difficulties, cognitive difficulties, and they need intervention. ENT, like I said, for hearing loss, eye, visual loss and impairment, and endocrine, because you can imagine depending on the tumor type, it can affect the hypothalamus, the pituitary gland, and you will need the endocrine or endocrine colleagues on board for a replacement of hormones. So these are just a few late effects that I wanted to highlight that our children unfortunately develop after multimodal therapy. So the main thing, of course, is neurocognition, which can be seen as an IQ drop, problems with memory and attention. And as a GP or family doctor, you may see them struggling in school, having learning problems, problem-solving difficulties. In endocrine, you may affect all of the hormones, and you can have poor height velocity, weight changes, pubertal anomalies, amenorrhea. And hearing, like I mentioned, because of the RT and the cisplatin, you can have hearing difficulties, speech delay, tinnitus. Vision, because of the location of the tumor, you may have visual field deficits if it's optic glioma along the optic tract. You may have cataracts if you got RT. And the symptoms you may have are visual changes, double vision, and decreased acuity. Neurological symptoms, depending on where the tumor was, you can have ataxia, paresis, seizures, tremors. Dental, typically we get our dentist to assess as well, because if they do get RT that goes around the dentition, then you may have osteonecrosis, gum problems, poor dentition. So it's very important to have the teeth checked and cleaned. And for our cardiovascular late effects, if you get RT to the brain, there may be some higher risk for vasculopathy. And of course, these patients, depending on where you did the RT and also what chemo they got, they are at higher risk for metabolic syndrome, hypertension, dyslipidemia, and all these must be well controlled by the family a decade's time. So I would say that after completion of therapy, let's say they go back to the community, and you see that there's a history of a brain tumor, you must always be aware that there is a possibility of relapse. For example, low-grade glioma can occur anytime. The ependymoma can even recur decades later. So it's important to reevaluate potential recurrence with new red flag symptoms. Open up the growth chart, see if they're growing well. Promote a healthy and active lifestyle. And of course, monitor for psychosocial effects, depression, anxiety. And also just check the chart and make sure that the child is still being followed up by a pediatric oncologist or a late effects clinic, just to make sure that someone is covering all the bases. So I just like to close with a few cases that are important, I feel, to how children can present. So the first case is an almost 2-year-old boy, ex-prem 33 weeker with some motor delay on follow-up with our child developmental unit already. And this child actually presented 3 times before the child was diagnosed with a tumor. So the first visit was to children's emergency with vomiting and fever. Of course, you think vomiting and fever is quite common, can be gastroenteritis, UTI. Basically, if he was eventually diagnosed with viral GE and given symptomatics and a follow-up. The second visit was to a walk-in clinic on day 7 of symptoms. He was lethargic looking, vomited 7 times, and advised to admit, but mom was a CKD patient, so had dialysis for herself, so was just monitored in clinic and given red flags. And the final third visit to CE, he basically had 10 days of vomiting already, and noted upon examination, the OFC was about 50 cm, which is quite large. I'll show the chart in a while, and truncal ataxia. And because of the prolonged symptoms, all these red flags, the consideration was for raised ICP and probably a space-occupying lesion. So you can see here at presentation, the OFC was about 90th to 97th centile. But the problem is that this child, although was born premature, you can see clearly that he was already just at the 3rd to 10th centile early on. And the speed of rise of the microcephaly was quite steep. And in the end, there was a large mass in the posterior fossa with mass effect and complete effacement of the fourth ventricle and severe hydrocephalus with CSF transudation. So this child was started on IV dexamethasone. We inserted, there was an EVD inserted and then eventually changed to a VP shunt. He got surgery for debulking and a biopsy confirmed a low-grade glioma, which is FGFR mutated. So he was started on IV chemotherapy, anti-VEGF therapy, and continued on follow-up. So he's doing quite well, I would say. The developmental milestones are improving, but there's still a persistent tumor, which is quite typical for an incompletely resected LGG because of the sensitive location. So the next case is 8.5-year-old girl who was identified to have poor weight gain, which was initially attributed to poor caloric intake and picky eating. The height velocity prior to evaluation was about 4.8 cm per year, which is still not too bad. But during follow-up or serial follow-up, she only gained additional 0.8 cm over 6 months, which is about 1.6 per year. Typically, you want to see at this age group a height gain of about 4 to 6 per year. So this was a significant red flag. So she was evaluated for growth hormone deficiency, and it was confirmed. And MRI, brain, and PIT was done in view of the growth hormone deficiency. So you can see here that actually at the age of evaluation, she was just hovering at the 3rd centile. But you can see the growth curve flattening out, which is a red flag. And eventually, a pituitary tumor was noted. So she had an endoscopic transsphenoidal biopsy, which confirmed germinoma. And typically for germ cell tumors, we do, and other brain tumors, we do also look for dissemination or metastases. And there was no dissemination, and she underwent chemotherapy and proton beam therapy. And currently she's in remission, but she does have the residual complications of growth hormone deficiency, central DI, central hypocortisolism, and of course, neurocognitive deficits. So the last case I would like to show is a case actually I saw as a junior MO. Um, so he was a 16 years old boy at that time and presented to children's emergency for a 2 week history of nausea, vomiting, low mood, blank staring, anhedonia, decreased interaction with friends, increased somnolence, not touching his gadgets for over 2 weeks, poor memory over the 2 weeks. And some red flags were that he was wetting the bed daily for the past 5 days. So a lot of very non-specific behavioral change, psychiatric symptoms. And I remember not once did he say that he had any headache or any with the vomiting or nausea. So clinical examination showed that he was lying in bed, eyes closed, refused to make verbal replies. And during morning rounds, he had a spontaneous enuresis. And I think the psychiatrist did ask him like memory kind of questions, like who was the current prime minister? He said Lee Kuan Yew in 2019, unable to recall three objects and unable to do serial sevens. So the psychiatrist at that time recommended MRI in view of the rapid progression. And they were right with cyst formation and obstructive hydrocephalus. So retrospectively, later on, the neurologist also took a look, and actually he did have clinical exam features that were red flags, like this margin was blurred, there was a superior gaze palsy, and the bilateral pupils were dilated and sluggish to light. So this is was in keeping with Parinod syndrome, where you can have the supranuclear gaze palsy, dilated pupils, lid retraction as well. So it was very. So I just wanted to highlight this because it's very important to do a good clinical examination, especially in a child you might think just actually has a psychiatric problem, but actually points I want them, developmental delay, increasing head circumference. Of course, you can have the easy to spot red flags of headaches, vomiting, and seizures, but don't forget the more subtle signs of poor growth and growth delay and acute changes of behavior, like apparently psychiatric symptoms. That's all I wanted to share. If there are any questions, you can let me know. You can ask in the chat. I put the email for appointments here if you ever need someone to see a child who you think may have a brain tumor, and my own email if you have any questions. Okay, thank
Thank
you.
you very much for that, Jen. I think that was a very good comprehensive talk and a good overview of pediatric brain tumors. I think it also put in perspective what our family physician colleagues can do in terms of late follow-up for many of these patients who are survivors and return back to the community. So Dr. Jen may have to log off before the session ends, but he will be around for the next 50 minutes or so. So if you have any questions for him, please do type it in the Q&A box and he'll try to address them before he leaves. Okay, so now we will transition to the adult neuro-oncology. So for the adult neuro-oncology, we've also tried to keep it very general. We've selected a few cases where we commonly encounter, and we wanted to focus on how these patients presented and some sort of overview of the management principles in each of these cases. So to help me today, I have Dr. Chia Yita. He's a resident in the Department of Radiation Oncology. So he'll be presenting the cases. We have selected 3 cases, and after each case, I'll just touch on the management points. And at the end, we can have a sort of a summary, and we will go through whatever questions you may have in the chat box. Ita, over to you. We can't hear you, Ita.
Hi everyone. So I'm Ida. I'm one of the residents from Radiation Oncology. Today we'll be presenting about the bread and butter of adult neuro-oncology. And then we have 3 cases to illustrate the various common conditions that we see in adult neuro-oncology. Okay, so these are the brief overviews and the objectives of today's talk. We are going to discuss common adult brain tumors, namely the glioblastoma, meningioma, as well as brain metastasis. And then we'll review the general management principles and also discuss the family physician's role in ongoing care. Okay, so starting off with the epidemiology and the importance. So the primary brain tumors account for about 1 to 2% of all adult cancers. And secondary tumors, which are brain mets, contribute to the biggest burden of adult neuro-oncology. And the detection rates are on the rise due to improved imaging with MRI. And with advancement in the treatment, survival of our patients have also improved, making shared care increasingly essential. Yeah, so general approach to a brain mass. So typical presentation includes that of a persistent headache, seizures, focal neurological deficits such as limb weakness, numbness, nausea, vomiting, cognitive behavioral changes, as well as diplopia if it happens to involve like the optic tracts. Yeah, so actually the symptom complex really depends on the location since there are various regions in the brain that account for different functions. So over here is a brief summary. So frontal lobe accounts for like our personality, our speech. So there may be some personality changes, dementia. For parietal lobe, maybe some receptive aphasia, sensory loss, hemianopia. Temporal lobe, there can also be seizures, complex, partial, or generalized. Occipital lobe usually will be vision related. The thalamus-wise, contralateral, sensory loss, behavior change, language disorders. And then cerebellum will be ataxia, dysmetria, and nystagmus. And lastly, for brainstem, cranial nerve dysfunctions, ataxia, papillary abnormalities, etc. All right, so after the initial presentation, we'll need to further evaluate with imaging. So an early imaging evaluation or early referral to a tertiary center is often required. And the preferred initial imaging for suspected malignancy would be that of MRI brain with contrast. Alternatively, would be CT brain with contrast, but usually it gives slightly poorer image quality compared to the MRI. All right, so we'll discuss the first case. The first case is Miss A. She's a 40-year-old lady working in admin. Her medical history includes type 2 DM, asthma, 2 malignancies, which are endometrial and ascending colon, which are both currently on surveillance, and she has also diagnosed Lynch syndrome. So she presented with 1 week acute onset of left arm weakness and gait unsteadiness, for which she went to see the polyclinic and she was referred to the ED for concerns of an acute stroke. So these are some screenshots taken from her initial consultation at the emergency department. So as you can see, overall, her presentation appears quite similar to that of an acute stroke. But in her case, she would have been out of window. So an initial non-contrasted CT brain was performed, which showed loss of gray-white differentiation predominantly seen in the right parietal lobe with evidence of cytotoxic edema. And then further on, MRI brain was performed to further characterize the changes on the CT, and it reported a right frontal parietal lesion, with main consideration being a primary CNS tumor, and differentials include infective and inflammatory changes. So on the right side, the picture above is the CT image, and the picture below are the MRI images, and you can see that there are corresponding changes in the right parietal lobe. As the patient was admitted at that point in time, she was worked up for infective and inflammatory changes, which came back to be negative. So Miss A thereafter underwent a stereotactic biopsy of the right frontal parietal lesion by our neurosurgical team, and the pathological report came back as high-grade glioma, ADH wild type, and MGMT methylated. Subsequently, she received 6 weeks of radiotherapy with daily temozolomide, followed by 6 cycles of monthly temozolomide as per the STOOP protocol. And during the early part of her treatment, she had to be admitted as she developed seizure, and she was started on levetiracetam, which is also known as Keppra, and also oral dexamethasone was started to reduce tumor edema, and it was tapered off upon completion of her treatment. So subsequently, she remained on close surveillance with regular MRIs, but unfortunately developed disease recurrence in new lesions in the right cerebrum about 8 months post-chemo RT, and the previously treated lesions were stable on the follow-up MRI. She was started on second-line systemic treatment and also underwent a craniotomy and resection of her right frontal lesion as it was symptomatic. The pathology report of the resected lesion was glioblastoma, IDH wild type, CNS WHO grade 4. Now I'll hand the time back to Dr. Bala to share more on glioblastomas.
Yeah, so the important thing to illustrate about this case is that this patient didn't have that much headache. She presented with some weakness, contralateral weakness, which resembled a stroke or a space-occupying lesion. And the other important thing to mention is also the initial MRI did not show a contrast-enhancing lesion. So this was a non-enhancing tumor, which is why the team initially suspected an inflammatory or infective sort of pathology. But within brain tumors, there are some which are not enhancing, and the majority are the high-grade ones tend to be enhancing, which means they trick up the contrast either on CT or MRI. And the other thing is that for sometimes in primary care, we think that this patient is young, so unlikely they will have a malignancy. But somehow for primary brain malignancies, they can also affect the slightly younger population, 40 to 60 years old. But also it's also seen in the older population, particularly the more aggressive primary brain tumors. So this patient was diagnosed to have a glioblastoma. Like I mentioned in the introduction, this is the most common primary brain malignancy in terms of brain high grade tumors. The median age tends to be around 50 to 60 years old. This is, I'm sure many of us have read about this in the news reports. There are many high-profile patients who have reported to have glioblastomas, and unfortunately, despite the many years of research and treatment protocols, the survival has not improved significantly. I think treatment has improved survival from previously about 6 to 9 months, which is now double, but still many of these patients perish from their illness, typically at about 1.5 to 2 years. This is a highly infiltrative tumor, so surgery is very, very important to remove the bulk of the disease, and that relieves many of the symptoms as well. But these tumors actually go into the normal brain parenchyma surrounding of what you can see on the scan. And this is where recurrences occur as well. And surgery is usually the first port of call. This gives us the diagnosis and also the molecular profile of the tumor. And surgery, depending on the location, they may not be able to resect all of the tumor, particularly if resecting that part of the tumor will leave the patient in a worse off state. They do what is called a maximal safe resection. And at NUH, we also focus on functional preservation. So we do have advanced techniques such as motor mapping, awake craniotomies, and things like that to actually preserve the patient's function post-treatment so that they're well enough to receive adjuvant therapy and also maintain their quality of life, post-surgery. So for glioblastomas, after surgery, most of these patients require adjuvant treatment, which typically involves a course of radiation treatment of about 6 weeks. And this is combined with some tablet chemotherapy called temozolomide. And this is typically called the SOUP protocol, which was established many years ago and is still the standard of care. Following the 6 weeks of chemo radiation, patients actually have a period of chemotherapy alone for 6 to 12 cycles, which is 6 to 12 months. And these patients are monitored usually with serial MRI scans every 3 months to check how the patient is doing in terms of the tumor response or the possibility of recurrences. Like what is mentioned on the last point here, there are some new updates of what we can offer these patients. So tumor treating fields is a sort of a new option that we have where electric fields are used to disrupt the mitotic activity of these cells. But the downside is that the patients do require to wear a patch over their scalp and be hooked up to a battery pack for about 18 hours a day. It has been shown to be useful in terms of delaying recurrence and prolonging survival. But eventually, most of these tumors do come back, but treatment does delay that as long as possible. Next slide. So the typically, glioblastoma is diagnosed based on the microscopic picture of the resected specimen. That hasn't changed. It's still considered grade 4 WHO, grade 4 glioma, high-grade glioma. But there are some molecular markers which we routinely test for in our current practice, which stratifies whether these tumors may respond better to chemotherapy, and also some prognostic markers like IDH. So, for example, if the patient has got a MGMT methylation, they actually respond better to temozolomide chemotherapy, and they also have a better overall prognosis. So it's both a predictive and a prognostic marker. And this IDH marker is also something that helps us stratify these gliomas. So in the past, we used to say as long as it looks like the GBM under the microscope, it's considered a glioblastoma. But now, even on the microscope, it may look very aggressive, but if they have IDH mutation, that suggests that they have a slightly better prognosis, and these are reclassified as a CNS grade 4 astrocytomas and not a glioblastoma. The treatment principles and management doesn't change even if they have IDH mutation, but however, the prognosis is better for these cases. So following treatment, we do see the patients roughly every 3 months at our clinic. We usually have a shared care model where the care is rotated between the specialists involved in the patient's management, such as the neurosurgical team, the medical oncology team, and the radiation oncology team. Patients do get a scan every 3 months, and sometimes we see what is called an inflammatory reaction, which makes the scan look worse, but actually this is actually just the tumor responding to the treatment. And very often down the road, 15, 18 months, we do see regrowth of the tumor. And at that time, we reevaluate whether the patient is suitable to have a further treatment, such as a second surgery, a second-line chemotherapy, or re-radiation. So the family physician's role. So clearly, I think where the family physician can play a role in managing these patients, particularly when they're back in the community, is that some patients may have prolonged symptoms post-treatment, such as prolonged fatigue. They may have cognitive changes, both as a result of where the tumor is located and also as a result of the treatment. Some of these patients may be on slightly longer-term steroid usage, particularly if there is prolonged symptomatic edema. They may be placed on dexamethasone, and that causes hyperglycemia in quite a number of patients, and this may need to be titrated. Their diabetic medications may need to be titrated, and some of them are also put on a short-acting insulin to reduce their hyperglycemia. Many of these patients are also on anti-seizure medications, particularly if they had a seizure at the time of diagnosis. They are usually kept on prophylactic AEDs, typically Keppra. Sometimes they may need more than one agent to get the seizures under control. Another place where family physicians can play a role is also when the patients are more towards the end of life in terms of palliative care and community support. And one thing we're trying to introduce a bit earlier in our patients where we know the prognosis is going to be short is to do their legal matters early on when their cognition is still intact, rather than leaving it to the end when decision-making capacity can be a bit challenged. So family physicians who have capacity to do LPA may initiate this earlier with the patients they're familiar with. Okay, we'll go to the next case.
Okay, so our next case is Mr. B, a 60-year-old taxi driver. So he first presented with acute left otitis media, and his initial CT temporal bone showed left otitis media and mastoiditis associated with an adjacent area of enhancement in the left temporal lobe indeterminate for inflammatory reactive changes or encephalitis. An MRI brain was also done, which showed a left medial cranial fossa mass with extracranial extension favoring a meningioma. So on the right side, the above image is from the CT, which shows the left middle ear and mastoid air spaces, which are filled with something of equivalent radial density as soft tissue. And on the MRI images below, the left medial cranial fossa mass is much more obvious and appears to be very locally infiltrative. Mr. B then underwent a left temporal craniotomy and resection of the sphenoid wing tumor. The histopathology report came back as WHO grade 1 meningioma. A post-op MRI brain was done and it showed suspicion of residual tumor, which you can see on the images on the right. There is still some residual enhancing areas at the medial aspect of the surgical cavity. The option of adjuvant radiotherapy was discussed. However, Mr. B eventually opted for close monitoring. So over the next few years, the residual meningioma showed gradual progression. He was discussed at the multidisciplinary tumor board, and recommendation was made for radiotherapy as the surgeons felt that debulking surgery is unlikely to achieve a cure. Eventually, Mr. B was agreeable for adjuvant radiotherapy, and he was treated with fractionated radiotherapy for 6 weeks. Proton beam therapy had also been discussed, but patient had declined due to cost consideration. As part of radiotherapy planning, a dotate PET was used for target delineation. So on the right, the above two images are the MRI images. When we compare them with the bottom left dotate PET images, we can see that the disease area can be much clearly identified on the PET images. Using the information from the PET images, we are able to ensure that a high radiation dose coverage to the active disease, and the high radiation dose region is marked by the green line in the bottom right radiotherapy planning images. So now I'll pass the time back to Dr. Bala to share further regarding meningiomas.
Yeah, so although the first case GBM is the most aggressive and most common primary brain malignancy that we see, actually the most primary common brain tumor that we see is meningiomas. It's actually quite common, and particularly when scans are done for other reasons, we note that these patients also have meningiomas. So for meningiomas, they often, like I mentioned, present with incidental findings, which means patients have no symptoms, or patients may have very, very slowly progressive symptoms. And these symptom complex depends on the location of the meningioma. So meningiomas are basically tumors which grow on the lining of the brain called the meninges. The typical locations are usually the convexity, the fall sign area, or sometimes skull base area, and the posterior fossa. So the symptoms that the patients present with are related to where the meningioma is growing. For meningiomas, typically we see it in the slightly older patients, but there are also some young patients who develop meningiomas, and this may be related to certain genetic syndromes they may have. We tend to divide them by the WHO grade. So grade 1 is considered benign meningiomas, grade 2s are atypical/intermediate meningiomas, and grade 3s are considered aggressive meningiomas. So thankfully, grade 1s are the most common. So these are really slow growing, very indolent. Often, they don't really affect the patient's lifespan. If the patient is usually, I think we'll go through that in the next slide, but usually the outcomes are quite good and the recurrence rates are low when a grade 1 meningioma is encountered. On the other end of the spectrum is grade 3 meningiomas. These are quite rare, but they behave more like cancers. They do not really metastasize, but the chance of local recurrence is high even with treatment. So both grade 2 and grade 3 meningiomas, we do recommend treatment and not observing these patients who are asymptomatic. As you can see, the 10-year survival does change, where grade 1 meningiomas, patients usually have a very good lifespan. It may not affect their lifespan if it's a small meningioma, whereas grade 2 and grade 3, it may affect their lifespan and cost them their lives should it not be controlled. Just back to the case. So this was an interesting case because this patient actually presented with otitis media. So it's a symptom that the family physician may see initially, and he was treated for this for many weeks or months before he presented. And the reason for this is that this is a skull-based meningioma which is going into the inner ear, and that was it was actually going out into the auditory canal, and that's why he was having these symptoms. So his symptoms have actually resolved with the treatment, and the tumor is actually well controlled now. So if I can just touch on the management principles very briefly, like I mentioned, grade 1s, they are quite indolent and benign. Sometimes the elderly patients with small meningiomas, these can just be observed. It can just be left alone, and it probably won't cause any problems or symptoms to the patient. If it is on the larger side and causing symptoms, we do recommend surgery as the first option, and often is the only treatment that's required. If the tumor can be removed in entirety, usually the recurrence rate is very low and the patient does not require any subsequent treatments. There are some locations where it's a benign tumor, but surgery is considered risky. For example, if it's in the cavernous sinus, skull base, surgery still can be done, but comes with a bit more risk compared to a convexity meningioma. So for these other patients, primary radiation therapy can be used as well. But the main difference between these two is that surgery removes the mass effect, whereas radiation mainly freezes the tumor. So it prevents the tumor from growing with a 90% chance of control, but does not remove the mass effect. So that's the difference between surgical approach and a radiation approach for grade 1s. For grade 2s, like I mentioned, this behavior can be a bit varied. Some of them recur quite quickly, they grow quite fast. Surgery is still the first option. We do not recommend observation in these cases. And sometimes we give them post-operative treatment, depending on some risk factors, to reduce the risk of recurrences. And grade 3s, they're usually more aggressive, and we do recommend post-op radiation in all patients. Okay, next slide. And generally, we'll survey them with MRI scan every 6 to 12 months. And many of these grade 1, grade 2 patients are actually cured and fully functional. Next slide. So the role would be mainly to monitor for the patient's neurological function or for new symptoms, and also the long-term management of complications such as endocrine replacement, hearing impairment, memory changes. Next slide. Okay, we are running a bit short on time, so we'll be a bit quick with case 3, then we'll leave some time for Q&A.
Okay, for case 3, is Miss C, a 47-year-old admin worker as well. So she was diagnosed upfront with metastatic HER2 positive right breast cancer to the brain, lymph nodes, bones, peritoneum, and adrenal glands. The initial MRI brain showed, with contrast, showed numerous enhancing supra- and infratemporal brain lesions with surrounding edema and local mass effect associated with patchy and leptomeningeal enhancement. She was treated with 2 weeks of whole brain radiotherapy and started on palliative intense systemic treatment. So here you can see the numerous brain metastases on the top left-hand side images. And in the bottom left-hand side images, you can see the presence of the leptomeningeal enhancement along the sulcus lines of the cerebellum, suggestive of leptomeningeal disease. On the right-hand side is a radiation planning image showing whole brain radiotherapy, where the entire brain is irradiated for local control of the intracranial disease. So after initial diagnosis, Miss C continued to receive further treatment. Gamma knife surgery was administered 6 months after initial whole brain RT due to progressing intracranial disease. She also progressed on several lines of systemic treatment, namely capecitabine, tucatinib, Herceptin for 1 year, then TDXD for 14 months, then capecitabine with lapatinib for 4 months, and then capecitabine and naratinib for 6 months. Thereafter, which is 3 years after the initial GKS, she received another course of GKS to the right occipital lesion and fractionated RT to posterior fossa lesions. The CT images on the right show the intracranial disease burden, especially in the posterior cranial fossa. Now, the left-hand side image shows the area of treatment for her second course of GKS to the right occipital lesion, while the right-hand side images are from the radiotherapy plan showing the high-dose area coverage to the posterior cranial fossa lesions, which is marked by the bright green line. So Miss C continued to survive for 5 years after the initial diagnosis of her brain metastasis, and she had decent function and quality of life until the final few months. There were treatment-related side effects, but they were manageable by the patient as well as her family, and eventually she was transferred to an inpatient hospice and passed away from progressive brain metastasis. Now back to Dr. Bala to discuss brain metastasis.
Okay, so I'll be quite brief with this case. So brain mets is, as we know, it's more commonly seen with breast and lung cancer patients. For this particular patient, we were quite aggressive with the management. Typically, the survival of patients with brain metastasis has always been less than a year in most cases. But in this case, as you can see, through the use of advanced techniques such as radiosurgery, fractionated treatments, and also advanced drugs which now can penetrate into the brain. This patient was actually kept alive with the brain disease under control for many, many years. So I think the point we want to make is that the management of brain mets is evolving, and patients sometimes do survive much more than what we anticipate them to based on statistics. Next slide. Yeah. Okay, next one. Yeah, so in terms of management, like I said, if they are large and they are large lesions calling mass effect, surgery is still required. In other patients where it's more limited and not causing any mass effect symptoms, we tend to use focused radiation, which works very well. Some patients with multiple lesions and also leptomeningeal involvement, we need a more general form of radiation called whole brain treatment. And often now for lung cancer and certain types of HER2 positive breast cancers, we can have certain drugs which work very well for brain mets. Next slide. So in terms of follow-up, what we usually do is that we usually scan them every 3 months, particularly if they have good prognosis and salvage treatment is possible. For the family physician, some of these patients may be on steroids for controlling edema. So managing steroid-related side effects is important. Sometimes patients may be on anti-epileptic drugs as well, particularly if they have a prior seizure. Next slide. Okay, next slide. So we went through 3 cases today. One is a glioblastoma, where we see the different types of management which were used and also the usual prognosis, which is listed there. The role of the family physician is more for symptom control and surveillance. Surveillance, the patients still do usually come back to the tertiary center, but there are some patients who have a slightly lower grade glioma who may be long survivors, and we will involve the community physicians as well. Meningiomas prognosis is usually excellent, and the family physician can play a role in surveillance and monitoring them as well. Most of them require some form of imaging every 6 to 12 months to monitor the meningioma. And in terms of brain metastasis, the prognosis can be variable. Managing the quality of life is something that we should look into engaging our community partners. Next slide. So our summary slide is that the care pathways can be streamlined between the neuro-oncologists in the tertiary institutions and family physicians in primary care, particularly for the patients who are longer survivors and they'll be back in the community to continue their follow-up. And the family physicians can play a role in the early detection of relapse, symptom management, and introduction of community support. Next slide. So we just in the 1 or 2 minutes, we wanted to just touch on a few points. So like headaches usually present as one of the main symptoms as we shared in our first few slides. And this table was taken from a family physician journal. So there are certain features which suggest that this may be more than just a primary headache. And these are listed here. And these may be related to more of some mass malignant tumor-related lesion within the brain. So these are things to look out for. In terms of physical examination, it's quite difficult to do a comprehensive examination, but we have listed down the kind of things that can be done as part of screening in the primary practice. Next slide. And I know most of the physicians within the polyclinics do not initiate a CT or MRI scan when they have patients with symptoms. But for our GP partners who do have access to imaging, there are some indications as suggested by these ACE guidelines where they can consider early access to early imaging if patients do have suspicious symptoms which may be more than just of a primary headache. Next slide. And in terms of when you should refer patients early, either through the ED or direct access to clinic, is if they have new or worsening neurological deficits, severe headaches, seizures, visual changes, or rapidly progressing cognitive or behavioral changes. So ED is definitely easier to access, but just say the symptoms are not so severe or patient refuses to go to ED, you can also get a direct access to one of our clinics. Typically, it'll go to internal medicine and neurology first to work up the symptoms. Unless the patient already has a known sort of a space-occupying lesion, then they can refer to our neurosurgical clinics directly as well. So in terms of our polyclinic partners, they will usually go through Epic to make the referral. But for our GP partners, you can also consider going through this channel to get early access to our clinics. Next slide. So in conclusion, brain tumor care is becoming increasingly multidisciplinary, including our primary care partners as well. Patients do have improved outcomes as treatments evolve and may be more commonly encountered in primary care settings. And we do want to engage our family physicians to be key partners in continued care. Okay, with that, I'd like to thank you for your attention. We are just a minute over time. There is a question in the chat box. I'll just take a minute to address that. So is proton beam therapy better than RT for most brain tumors? So proton beam therapy is a form of energy-based treatment, which is also a form of radiation, uses particles. The advantage of proton beam therapy is in selected brain tumor patients, particularly the patients with primary brain tumors, and in particular, pediatric brain tumors benefit from proton therapy because the late effects such as secondary malignancies are reduced when you use proton beam treatment. And within adults, there are certain locations which are also more suited for proton beam therapy. For example, skull-based lesions or lesions near the optic chiasm or near the certain critical areas where reduction in dosage can actually can translate to a clinical benefit for the patient. For patients with metastatic disease, which is the bulk of our cases, there's very limited benefit of proton beam therapy, because most of these patients require to be survivors for usually 5 years or longer to reap the benefits of proton beam therapy. So although it may not be inferior in terms of control, the benefits are not seen in that group of patients. Okay, so I hope that answers your question. Once again, I want to thank you for joining us today in this hour for our second GP symposium for 2025. I hope this overview has been useful to you in your practice, and also I hope that we will keep engaging you for future events. Like I mentioned, we do have a public symposium in 2 weeks, and you're more than welcome to join us at that event as well. So with that, I'd like to thank you and end the symposium.